We're going to start things off with Andrew Reed from Penn State. He's going to tell us about antibiotic resistance and the problem of treating patients. Take it away.
Okay, thanks very much. Can you hear me okay back there? Can you hear me too much? I want to start with a couple of advertisements. The first one is that I'm in the market for postdocs, mathematicians, and experimentalists. The second one is that Andrea Graham led a successful application for a research coordination network, which is in the infectious disease area, but I think we could sneak a bit of cancer in as well, which among other things allows young folk, by which I mean pretty serious senior postdocs right down to graduate students, to move between labs for pretty significant amounts of time. So if you are interested in spending some time in my lab or others, check out this website. I love the fact that there's a website, ideas.princeton. There's only one such website, and it's ours. That's the Ideas at Princeton. Okay, you all know that when you get a course of antibiotics, the physician urges you to take the whole course, and she tells you to do that, keep doing that, even if you feel better. That's true in the first world if we are using antibiotics for viral infections, or correctly for bacterial infections, or for antimalarials in a developing world context. And the philosophy here is that we are going to try to get rid of all the bugs. And the plan, of course, from a resistance management point of view, is to try to prevent the emergence of resistance by making sure we're fully compliant with these requirements. This has always struck me as a bit weird. This is what causes drug resistance evolution. It's the drugs. Okay, no drugs, no drug resistance. It's as simple as that. And so our solution to the problem of drug resistance is to use more of the thing which causes it. At the face of it, it's not immediately obvious that is the right thing to do. The selection pressure that generates drug resistance is the use of the drugs. So if you keep using drugs long after you no longer need them for clinical need, you're continuing to impose selection for resistance without clinical need. And it's not obvious that that is the correct thing to do. The issue here is that this firebombing of, and this is also true for cancers, this chemical warfare, we're attacking everything, does a great job of removing the sensitive bugs. And so if there is anything resistant in there, the world is left to that thing. The very thing we don't want to promote gets a really significant break if it's present and we start to firebomb our bodies. And so the question is, why are we doing this? Why are we overusing, using antibiotics, antimicrobials beyond clinical need? And the argument is, from a resistance management point of view at least, that it's good to kill bugs because bugs don't mutate to resistance. So killing sensitives is a great way to stop resistance. And of course that's true. You can prevent the acquisition of resistance in the first place by killing those things that would acquire the plasmids or mutate to resistance. But you do it at the cost of maximizing selection for any resistant ones that are already there. Okay? So there's what we call a double-edged sword of aggressive chemotherapy. You stop the bugs that could mutate in the first place, but you give maximum advantage to any that are already there by getting rid of all those sensitives. And so in cartoon form, well, this is real data on a malaria patient, parasite densities through time. So you drug treat, and the idea is that by getting rid of all those bugs, all of the ones that subsequently would have appeared can't mutate to resistance. So that's good for managing resistance. But if there's a resistant bug there, it's going to take over the world. So there's always two evolutionary forces set in place by drug treatment. These two, and they're in opposition, and it isn't possible, I assert, to know in advance which of those is the more important. You can't tell by sitting in your armchair and deciding which of those pressures is going to drive resistance faster than others. I assert, and I hope you take it from this talk, that it's an empirical problem that we don't have standard conventional, at least agreed answers to. Or at least the agreed ones I think are probably wrong, and the ones we need to work on are trying to figure out the situations where one of these forces is more important than the other. So then the question becomes, how should we treat patients? I think the aims of patient treatment are relatively straightforward. We want to make the patient healthier, we want the patient not to infect anybody else, and we want the patient not to drive resistance evolution, either for their own good or for those other patients in the hospital or community. and in some contexts we'd like to do that cheaply. Now those things are actually measurable. Nothing particularly hard about any of those. Practically there might be, but in principle are all easy things to measure. Now I'd love to do that sort of stuff on patients, but we're not there yet. What we've been doing is measuring these things in malaria infections in mice. This is one of the work we've been doing it now for a number of years in my lab. I think our cleanest data set is from pyrimethamine used to treat rodent malaria infections. Sylvie Halbin led the work. And what we found in those experiments was that the only thing that does really poorly of all the regimens we tried is the recommended guidelines. So if we use the maximum dose for the recommended duration, they do worse on one or all of those things if resistant parasites are around. The best thing to do in our experimental settings is in fact not to take the week-long course that's recommended, but to do it for just one day and actually cut the pill in half and use half of it. Okay? The best thing for all of those outcomes, not just resistance management, all of them, empirically the best thing in our hands is to take the pill just once and forget the rest of the course, and even better, cut that first pill in half. Okay, now this is mice and one type of infection, but I have to say that with this particular group of mice and these particular infections, it's starting to look to me very much like a good rule for the mice to take would be to take the drugs when they feel sick and stop taking them the minute they feel better. If they relapse and get sick again, take them again. Okay? Now you'll recognize that that is not a popular line of argument amongst the physician community, but empirically that is the best thing to do in our experiments. Now, when we published this paper, 2013, it's the hardest paper I've ever had to get accepted. It took more than 15 months. When it finally got to review, it's either boring or obvious or completely wrong. And that was what the reviewer said. Nobody disagreed with the experiments. They still think they are lovely experiments. It generated a lot of heat. One of the bits of heat was a group of the wise and the good got together to thrash out whether this could possibly be correct. I mean, our experiments show it, but people wanted to know, well, could this possibly be correct in general? So the group of us involved in reviewing the literature, that was scary in itself. This really important question, how much antibiotics to use, it turns out that it is possible to hold all of the papers involved in one person's head. If you exclude the stuff from chemostats, which doesn't tell you much about how to treat a patient, there's only in the order of between 15 and 20 empirical papers on this question, where the clinical outcomes are measured and the resistance management, the actual evolution, is measured as well. And I think it's a shockingly small database. And I'm also slightly embarrassed to say that the work of my group fills up a fairly large chunk of that empirical data. I just find that amazing. We just got into this a few years ago, and my group is making significant contributions to this paltry literature. Amazing. As an experimentalist, I'd love to show you some more data, so I'm just going to whiz through it. Artemisinin, which is the wonder drug for malaria treatment these days, the best thing to do is to use half the dose of the drug. Atovaquone, which is a component of Malarone, which is one of the antimalarials that you guys would use. Atovaquone resistance evolves very fast in the mice. The harder you hit them with drugs, the dose, the worse the level of resistance. This follows what we might call the Baber-Brinkman rule. The harder you hit them, the more resistant they become. So, empirically then, in my lab, in our malaria situations, it's better to back off. It's better to shorten the course and to lower the concentration of the antimalarials. So that raises the question of whether that's generally true. What's the generality here? This is always a tricky thing in infectious disease biology. What are the generalities and what are the specifics to the case involved? That's obviously where you turn to a mathematician. I've been working with Troy Day now for several years on this. Great thing when you ask Troy for something is he gives you an equation. Here's the equation. What's really nice about Troy's equations, though, a bit different from other people's, is you actually don't need to, you can just color the blocks. The shape of the equation tells you stuff. So on the top, there's two divisions there. There's the mutational inputs into the system, and then what we're calling reproduction or amplification, the subsequent growth of the resistance. And on the bottom is what we call the de novo hazard. That's the chances that resistance will arise de novo, and then the standing hazard, the chances that you got it from somebody else. So you can break it down to this component. This is the probability that resistance will emerge as a function of drug pressure. It boils down to all these components. The bits, I don't know if you can see at the back, there's some bits in blue there. That's to do with the ecology of what's going on in the infection. It's usually left out of such equations. It's the competitive release that happens when you get rid of the sensitives. and the resistant ones get the world to themselves. Now, just looking at this, we don't know the shape of those functions for any infection. We're just looking at this, you can see there's going to be a bunch of things that are going to increase the risk of resistance arising. For instance, the faster the mutation rate, the more likely resistance will arise. And then there's a bunch of stuff that will slow it down. For instance, the less drug you use, the weaker the selection for resistance. So that's all caught up in this sort of thing. I'm not going to mention that anymore. I'm going to try and give you some qualitative view of what happens with this equation. So this is kind of the picture. I think that's pretty clear here. So we have rate of evolution on the y-axis where we don't want resistance evolution. So the further up the y-axis we are, the worse it is. And then on the x-axis is drug pressure. So we've got these two processes. As drug pressure increases, then you get stronger strength of selection for resistance. So that pushes up the rate of evolution of resistance. And then if you use a lot of drugs, you start to kill bugs. And so they can't mutate to resistance. So the more drugs you use, the less mutational inputs there are into the system. So the slower the rate of evolution goes. So it's going to have a function of that sort of shape. Okay, those two opposing forces then are what gives that sort of shape. So what should you do then? Well, the standard conventional wisdom, let's hit them hard, assumes that there's a limit to what you can, clearly there's always going to be a limit to how much drug you can stick into the system, usually because of the damage you do to patients. Although sometimes there's a cost issue as well. If that cutoff, if that threshold is well to the right of the curve, then obviously you should hammer hard. Because if you can kill everything and stop evolution, that's great. But this is the most boring part of the problem, right? This is easy. You don't have a drug resistance problem here. You just hit them hard, everything dies, no evolution happens. Straightforward. So this is important but boring. The issue becomes more interesting if the limit is somewhere else. And in this case here, then you could go for as high as you can, but you can also see there are bits of parameter space where the rate of evolution is going to be slower. So you have options of either being here or lower down here. Okay, so it's not quite so straightforward what you do there. 3 minutes? Okay. If the curve is here, you should have less, you should always go down. The curves themselves have different places. What should you do? Depends on the curves and the thresholds. Okay, it's a very hard problem. We don't know those curves and thresholds. So my first point is that this is a really hard problem. Details matter. It matters whether it's HIV or TB or malaria or leprosy. You can't treat the same things the same way. It matters a lot. We don't know these underlying curves. The second point I want to make is that there's going to be a minimum that's a clinically useful amount of drug you should use. Okay? Now, if that's true, then another thing follows. The best solution is going to be either to do as much as you can or as little as you can. Okay? That follows from the shape of this thing. So that's always going to be the solution, one of those two. That's good. We narrowed the parameter space down to what should you do. We didn't get it down to an easy problem, though, because depending where you are, if you just toss a coin and choose one of those two, you can make it significantly worse. Okay? The other thing is, medicine is never operating at those limits. We always crank the dose up a bit to make sure there's enough to go around. So we, just make sure that enough gets in the system. So we never operate at the bottom. And then there are always patients, sorry, that shifts us up. And then there are always patients who don't get enough, so we're always operating a bit below there. So standard practice is always putting us in the zone which is bad. So the third point there is that standard practice is accelerating resistance evolution. And finally, I just want to make the point that it really matters what the mutational pressures into the system here is. We are dominated by HIV thinking. If you look at the list of resistant bacteria in the CDC, the ones they're very concerned about, most of those are acquired from somebody else. Forget the mutations. Your risk is other people. Under those circumstances, where resistance is already around, it does not make sense to hammer away with the drugs. And in fungicides, in crop systems, that is well understood, that high doses generate very fast evolution, which erodes the efficacy of the product much more rapidly than low doses. So I think we are doing the wrong thing in medicine in general, but it is not simple to say we should instead be doing something else. The details really matter here. So those are my take-home messages. It's a hard problem. We are playing with fire here. We don't really know what we're doing, and I think we really need an evidence base here where we measure evolutionary outcomes. Patient outcomes are sure, but also evolutionary outcomes. Thanks very much.